what is working, what's not working, and why is it that we would have this figure of 57%? What's your sense of what is causing us to have failed in this way? Why are we failing our children?
Very difficult question to answer. If we had the silver bullet, of course we would have already used it. Unfortunately, we still learning from the process. Yes, 20 percentage points difference of treatment of adults and children is across most of the countries in the region. Why? Because we haven't invested in testing of children as much as investing of testing of mothers. We haven't invested in finding cases of children, as my colleague from GPN Plus said, in communities. Let me state one study which we are finalizing, but preliminary findings of the study in Tanzania, when we tested 800 children in a community, we found those who are exposed ones, out of those 800 exposed children, we found 14% of them with HIV new infections. Why we have less percent of the children in the community be in the community and diagnosed? Is this a failure of the health system? Partially, yes. It is a failure of the follow-up system? Partially, yes. It is a failure of us to deploy community health workers to find those cases? Yes. What about family index testing? Are we really using this approach to find the cases? Not always. So I think that's a few kind of examples to say that we need to go to the communities. We have done relatively well, especially in Eastern Southern Africa, to provide testing treatment for mothers in health facilities, but it's time to go to the communities. And I think that's in line with the slogan of World AIDS Day this year, theme, communities to live. We need to give communities, community health workers, and communities empowered in order to tackle this issue of the low treatment coverage of children. Secondly, optimizing HIV testing services for pediatrics. We have only few POC machines here and there, but at the same time we have gene expert machines for other communicable diseases, used only for those diseases, but not shared with for the early infant diagnosis. Why? Can we optimize the services, make sure that the early infant diagnosis services are available in nearby health facilities, and then children can get their test results in shortest time possible? I always might ask myself, COVID-19, countries have struggled at the beginning, but after 6 months, most of the countries were providing COVID-19 test results within 24 hours, not just to the service provider, but to the individual, 24 hours. And it took countries 6 months, a lot of investment, but it was possible. Can we do the same approach for testing of children? I think it's feasible. It's just for us to look ways to increase testing of the children.
Thank you. Back to you, Anna.
So there are a number of social and structural barriers that really hinder access to services and that really hinder progress and also reaching children. And one of those is stigma and discrimination. It really plays a big role in terms of having people shy away from the facility, and also really ensuring that services don't reach the people. So a lot of young mothers, a lot of parents, a lot of caregivers, because of the stigma they face in the community, or within the health facility really then don't access services. And we know that when the parents and caregivers don't access services, it means the children also don't get to access the services. There are also issues with restrictive laws and policies targeted at key populations. For instance, children and babies of women living with HIV who identify also as same-sex. Sometimes it becomes difficult and challenging for them to access services fully in a way that they want to, or either programming sometimes only targets the mother and it leaves the children out. So there's really a challenge when it comes to that as well. And also the challenge around lack of integration of services. It also becomes a challenge when it accessing services. And also really the issue around cost of health to access services. For instance, the user fees that are paid that some might not be able to afford and also be fully be able to access services. So that also is a limitation. And also generally just looking at the different inequities that are faced by different populations of young mothers living with HIV within the different contexts. That also hinders access to services, and that also hinders us accessing the children. But also looking within the facility as well, I think there really is a challenge in terms of diagnostics for children. We are really not pushing and doing enough, ensuring that it's there. So if we find the children, can they have timely diagnosis? Can they be able to be supported and helped within facilities? So that really is an important issue where we need a lot of political and government will as well as domestic resources to ensure that machines are there and they are working. And then there's also the issue of lack of age-appropriate antiretrovirals for children. I think that's very, very important, especially when we are working with children. And there's a lot that needs to be done in terms of advancement and research and work to ensure that children can take their treatment in a dignified manner. They can have treatment that they accept, they can have treatments that they are that they don't fear taking, that they're very comfortable in taking. And also the parents are not fearful of administering that treatment.
Thank you so much. Peter, let me just ask you a question. I noticed in some of the data in some countries that in the last 2 or 3 years, we saw a bit of a surge in the number of children being born HIV positive in some of the countries. We also saw at the same time a surge in teenage pregnancy. And just to get a sense from you, are we seeing a trend? Can you identify where it is in the age cohort that we're seeing the greatest sort of missing children? Is it newborns? Is it young ones that we're missing? Or is it older children who've been living with HIV for a long period of time? Do you have a sense of this? And is there some correlation with this issue of a surge in teenage pregnancy?
Well, many colleagues would remember that about 20 years ago, one of the World AIDS Day slogans was, "Know your epidemic." After 20 years responding to HIV epidemic, I think it's time to us to look into the same issue, saying, "Know your epidemic better." Because we need to look into the epidemic not at the national level anymore. National level is just average of different provinces, sub-counties, health facilities. Now it's time for us to look into what is happening in your specific health facility, because at the end of the day, response at health facility. So the better we know what is happening in the country, the better we will be able to respond. But data collection starts with the health facility. Now to your question in terms of what is happening, COVID-19 was quite impactful in terms of number of things, including gender-based violence. And secondly, which is equally important to our issue with when we're discussing at ICASA, is STIs, and HIV, because it has impacted. What we see is that the number of pregnancies in the countries. That's why we have seen slight surge of this data coming from the country during those long lockdowns in the countries. Yes, that was observed, but slowly we are getting to the numbers of the pre-COVID. So that's good side, actually. We are getting back to so-called new normalcy of what was there before 2020. Where we look children, because health facilities well comes from established in terms of the testing and treatment. Most of the kids, as already we mentioned, it's in communities above the age of 2, where they are out of the health facilities periphery. They are out of the health facility service provision cycle. So many people ask, we don't find those kids. They are not there. Your numbers are wrong. Your spectrum is not telling us the truth. But if we go to the communities, we will find those kids. You know, not always with their biological parents, but sometimes, or most of the times, with their grandmother. Someone is taking care of their children because their parents somewhere else, working in the town, working in these other places, but because they are not their biological parents, we don't really see the link between HIV/AIDS and those children and biological grandparents or those who are taking guardians of those children. So more and more we go to the communities, we will see these children. We will see those children aged above, let's say, 2 years old, HIV, with some manifestation of the disease, but that needs to be done as quickly as possible to bring them to the health facility, to offer them not just testing, but treatment. So that's where it's really kind of important to look at different age groups equally, not just the ones who are going to the health facilities, making sure they are tested, those who are exposed to the HIV, but those who are seem to be not exposed, but those are in reality are HIV positive.
Thank you so much, Ida. We have just about 7 minutes to finish this session. Let me see if I can get some comments, questions from the floor. Anyone want to share some reflection from the floor? Yes, there's a hand over there in red. Do we have mics going around? And there's another hand on the right. There's a man at the back, and there's a man here in front, and there is a young woman there in red. Can we have mics going around, please? Yeah, this lady here. The lady in red, please. Oh, sorry, I see another lady at the back as well. We'll come to you. Thank you.
Thank you. My name is Macy. I'm here from Zimbabwe. And there are so many challenges we are facing to our community. Some of the rural clinics, they don't have the screening machines for the babies. So the other challenge we are facing that we are used to walk a long distance to go to the facility. And then we are said the nurses will attend or test the child. And they are used to say you will be back here for the results, or after 7 days or 3 days, you will come and take the results. So because of the distance, we are used to walk to go to the facility. Some of the mothers will fail to go back to the facility for the results. Then the other side, we found out that I once worked as a volunteer at GF Catholic. We were facing the challenges of that some young mothers will give false address. That is very difficult for us to identify where exactly the baby is, or the caregiver will not be able to be identified or the exactly village. So it will become a very big challenge. I don't know where can something.
Thank you so much. We appreciate that comment. Thank you. At the back, there's a hand there at the back.
Pardon, et bonjour. C'est juste pour dire qu'il n'y a pas de traduction dans la salle. Alors, si vous avez des questions, je peux peut-être juste faire la traduction pour vous, mais autrement, je pense que vous devrez aller dans une autre salle pour cet aspect. Merci.
It was a short announcement for the French-speaking community, and sorry for that.
Is there a translator? No. Is there anybody who's available or willing to translate?
That's what he offered.
Oh, that's what we are.
Okay, there's a young woman at the back there with a hand in a black.
Hi, thank you so much. My name is Joy Ubui. I'm from Nigeria. I work, I'm a young emerging leader with White Plus Global, and I also work for the Association of Positive Youth Living with HIV in Nigeria. So this is an interesting topic, and we've had wonderful insights from the speakers. My issue is that
But how much do we work through them? We run parallel programs. We want to do it ourselves, and when everything goes wrong, it is when the community say, oh, come, we are having a problem. It should stop. We should know that these communities are there, and if you want, because if you want to see my child, why would it be a problem? Why don't you come to me and I show you that this is my child and this is where you can get? But nobody comes to me as a mother, as a woman living with HIV. They only come to me when things go wrong. We are missing children. All of you women are on treatment, but you don't see children. Come to us and say, we want to have a comprehensive approach to reaching to you. Rather than now coming to me when everything has failed, because now we need children, now we are looking for women. Where are you? Why are we not seeing children? We've told you this before. So please, let's not engage for the sake of engaging. Let the engagement be meaningful, let the engagement be targeted at wanting to bring about the desired outcomes for all of us, for our children, and for the future in terms of public health. Thank you so much,
And just building up on that and what you've been speaking about, it really ties into the work that we're doing. And I just want to acknowledge the young mother in Epic Chapel who spoke first, who are really parents and caregivers who have their capacity strengthened in order to be working in the communities. And part of that group, we have also primary health counselors who are young mothers who are working within the facility, which makes it easier for them to be able to reach the communities. So I really think that's really important in terms of partnership, and in terms of also progressive collaboration. And then I just want to speak also to the issue of task shifting and really looking at it and thinking more around task sharing and really realizing the opportunity and the potential of communities. So yeah, I think that's what I'll just add.
Thank you so much, Anna. Leader.
The theme of ICASA is, as you know, AIDS is not over. But I'd like to put it in a positive way, that AIDS will be over once we tackle the issue of the loss to follow-up, as one of the ladies from the audience said. AIDS will be over once we tackle the issue of the age-appropriate disclosure. It will be over when we look into the reducing age of consent from 18 to 16. In some countries, we're able to do it, but we're able to do it after many years of advocacy, especially from the communities. People living with HIV, those who know that by decreasing or reducing age of the consent to lower ages, we will be able to get more cases identified and, most importantly, put on treatment. AIDS will be over when we know our epidemic better. And referring to your question about the data, age and sex disaggregated data this age is must. We need to know our epidemic, and these data should be available at lowest possible country level at the country, whether at the subnational level, whether at this facility level, but only by knowing this, what is happening in the particular place, we will be able to respond to these things quickly. So, answer is with you, it's not with us, with all the knowledge and the wisdom of the people sitting in this room and then attending this great conference, but its implementation that we should be working together. Thank you.
Thank you so much, Ida. And thank you all for staying beyond the time. We've actually stolen 24 minutes, which is a great steal in a conference. But really just to say in conclusion that the Global Alliance to End AIDS in Children is an alliance that must work. And it must work in ways that, I think, Lillian, from what you're saying, we have to really be very clear that how communities lead, we have seen the examples, but how do we get the investment to make that happen in a much more comprehensive way? And perhaps there needs to be a really strong part of the work that we do to strongly advocating for the investments in the communities and community organizations that have done this work so effectively. I think the issue of integration of services has to be an outcome of this global alliance. We cannot continue to have this almost divide and rule approach where we're scattering people, but I do hear on the training and capacities of the health providers. And so that becomes such a huge issue. And then also on the surveillance and the diagnostics and how do we get the investment. So, I mean, I think a big take home here is how do we get the investments in the right place? How do we increase the investments to go to the communities, to go to the integration of services? And the answers for how and where we find the children exist, it's for us to follow those experiences and be able to answer the question. From us, thank you very much for our panel, and each one of our panelists, and thank you, Anna and Ida, for stepping in early, and Lillian, thank you for coming in to sum it up really well, and thank me for stepping in as the MC.